It's a pleasure to be with you. The title of this session is Organization and Financing of Public Health, Part 11, Public Health Funding. There are no disclosures for this presentation. Objectives include review the role of the National Health Expenditures Accounts in monitoring public health funding, review federal public health funding, review federal public health funding trends, review pandemic impact funding, review the Public Health and Health Services PHHS block grant, review state public health funding, review local public health funding. Funding for the public health system primarily comes from taxes and fees collected by the government at the federal, state, and local levels. Accurately defining public health services funding from the funding of services from other healthcare disciplines is challenging. The National Health Expenditure Accounts, NHEA, administered under the Centers for Medicare and Medicaid, CMS, provides the most authoritative estimate of public health funding and spending. The NHEA categories include expenditures for healthcare goods and services, public health activities, government administration, the net cost of health insurance, and investment related to healthcare. NHEA public health activities categories include providing government healthcare to individual citizens, epidemiological surveillance, immunization vaccination services, disease prevention programs, and the operation of public health laboratories. Activities not included as NHEA public health activities include health research, government purchases of medical structures and equipment, emergency planning, and government spending for public works environmental functions, including air and water pollution abatement, sanitation and sewage treatment, and water supplies. Many public health practitioners would argue that these are also major public health services and activities and should be considered as public health funding and spending. Despite the limitations of these NHEA public health activities categories, the NHEA provides reasonable estimates of aggregate and categorical healthcare expenditures in the United States from 1960, providing a benchmark for trends and comparisons. Most federal public health activities and funding are associated with the Department of Health and Human Services, DHHS, especially the Food and Drug Administration, FDA, and the Centers for Disease Control and Prevention, CDC. Since the 9/11 attacks, substantial additional sources of public health funding comes from the Public Health and Social Services Emergency Fund applied through the DHHS Departmental Management Budget and the Department of Homeland Security. In response to the COVID-19 pandemic, the Public Health and Social Services Emergency Fund and the CDC budgets were significantly increased. Sources to estimate government public health activity and funding include the Executive Office of the President budget for federal agencies and the U.S. Census Bureau report produced every 5 years and the Bureau's annual survey of state and local government finances. Out of the $4.1 trillion budget in calendar year 2020, 5%, or $223.7 billion, was allocated to public health activities and services. This table lists a few NHEA public health activities expenditure trends From 1960 to 2020, total national health expenditures were $27.1 billion in 1960, increasing over 59 years to 3.8 trillion in 2019 and 4.1 trillion in 2020. Public health expenditures steadily increased from $0.4 billion in 1960 to 105 billion in 2019, and in 2020 more than doubled to reach $223.7 billion. Public health activities expenditures accounted for 1.4% of national health expenditures in 1960 and ranged from 2.5 to 3.2% between 1980 and 2019, jumping to 5.4% in 2020. Per capita expenditures in 1960 were $2 per person, increasing to $320 in 2019 and dramatically increased to $680 in 2020. The dramatic change of funding from 2019 to 2020 was related to the COVID-19 pandemic. This pandemic funding provided support for healthcare providers through CARES Act programs and increases in federal Medicaid funding and reimbursements. The CARES acronym stands for Coronavirus Aid, Relief, and Economic Security Act, a 2.2 trillion economic stimulus bill signed into law on March 27, 2020, in response to the economic fallout of the COVID-19 pandemic in the United States. The Provider Relief Fund was part of the CARES Act and provided payments to eligible providers who diagnose, test, or care for individuals with possible or actual cases of COVID-19 and have healthcare related expenses and lost revenues attributable to COVID-19. The Paycheck Protection Program, PPP, was also established by the CARES Act to provide small businesses with funds to pay up to 8 weeks of payroll costs, including benefits, and pay interest on mortgages, rent, and utilities. This pandemic funding also stimulated growth in both the healthcare and public health sectors. The federal public health budget is used in two ways: to fund federal activities and to fund state and local activities. Providing categorical grants is the most common method used by the CDC and other federal agencies to fund state and local public health efforts. Categorical grants are use restricted or must be used to meet a federally defined goal and cannot be used to support broader public health activities. Categorical grants are often criticized due to their rigid requirements and guidelines, with little freedom to adjust to the unique needs of state or local populations. The CDC's Preventive Health and Health Services Block Grant is an exception that allows for considerable flexibility in the use of those dollars. The Preventive Health and Health Services PHHS Block Grant Program allows the 50 states, the District of Columbia, 2 American Indian tribes, 5 U.S. territories, and 3 freely associated states to address their own unique public health needs and challenges with innovation, providing opportunities to address emerging health issues and gaps, to focus on the leading preventable risk factors associated with premature death and disability, to address social determinants associated with health equity and disparities, to support local programs that lead to healthy communities, and establish health data and surveillance systems. PHHS block grant funds have been used to provide clinical services, preventive screenings and services, outbreak control, workforce training, program evaluation, public education, data surveillance, chronic disease programs, injury and violence prevention, infectious disease control, environmental health, community fluoridation, tobacco prevention, and emergency medical response. The flexibility of the PHHS block grant is much appreciated by state and local health departments. State health departments obtain funding from federal, state, and other sources. Of these, the federal government provided approximately 53% of state public health funding between 2015 and 2018. The largest sources of those federal funds for states were from the Department of Agriculture, followed by the CDC, HRSA, and other DHHS programs, providing about 45% of state public health funding. State sources were the second largest source of funding for state health departments, providing about 28% of their budget. About 70% of state funding was from the state's general fund. As mentioned previously, most federal funding comes to states through categorical grants to be used only for purposes specified by grant guidance and can't be reallocated for other state health needs and priorities. This underlines the importance of state and other sources of funding to provide needed public health services not covered by federal grants. Yet each state government is unique with its own set of public health priorities, organizational structures, and public health services provided. This slide provides a few examples of the variability of state public health funding sources. In 2003, even though both Texas and California have decentralized public health systems, Texas appropriated 45% more state funds toward public health than California, spending $99.30 per person on public health versus $14.70 in California. Illinois' public health funding was primarily from federal and state sources, with over half of that from the state. Tennessee received no state or other funds for public health, with all their funding coming from the federal government, the Department of Agriculture, 39.5%, HRSA, 39%, the CDC, 13.5%, and other DHHS agencies, 8%. New Jersey received 45.8% of their public health funding from other sources, with additional significant funding coming from the federal government, primarily from the CMS Medicaid program, 55%. Local health departments obtain funding from a variety of sources, including local funds, 25%, state funds, 21%, federal pass-through via the state health department, 16%, federal direct funding, 11%, private foundations, 1%, other sources, 5%, and clinical services, 14%, including service reimbursements from Medicaid and Medicare, 10%, private insurance, 2%, and patient personal fees, 1%. The source and amount of funding depends on the governance structure of the local health department. Centralized departments, or those run by the state, as a mean received $3 per person from local sources, whereas locally governed departments, or those with a decentralized governance structure, received $21 per person, and those with a shared governance structure, $15 per person. Decentralized and shared departments received more funds from the state and federal government versus centralized departments. The population served by local health departments also influences per capita funding. In general, departments serving fewer than 50,000 people have the highest per capita funding compared to those serving larger populations. Urbanization also impacts funding, with urban departments substantially receiving less funding per capita than rural departments. So there is better per capita funding for small, rural, local public health departments that have a decentralized or shared governance structure in the United States. Census region also differentiates funding levels per capita. Local funding is lowest in the South, $14 per capita, and highest in the Midwest, $21 per capita. State funding is lowest in the Midwest, $3 per capita, and highest in the West, $33 per capita. Federal funding is highest in the West and South, and clinical funding is highest in the South and Midwest. Support for local public health may also come from a variety of community partners, including social and human service agencies, primary care providers, hospitals, businesses, community organizations, schools, churches, volunteer organizations, and citizens themselves, and depends on the local economy, market forces, political views, geography, and existing public health infrastructure. As Ashish Jha, White House COVID-19 response coordinator for the Biden administration, said, "We have a very complicated form of government in America, which is because we have a very complicated country. As a result, the ability to move policy resides at a lot of different levels. If you want to try to move it all in one direction, you have to coordinate and bring people along. That is a challenge for all of us in public health and is demonstrated by the complexity of public health funding." In summary, accurately defining public health services funding from the funding of services from other healthcare disciplines is challenging. The National Health Expenditure Accounts provides reasonable estimates of aggregate and categorical healthcare expenditures. Pandemic funding stimulated growth in both the healthcare and public health sectors. Providing categorical grants is the most common method used by federal agencies to fund state and local public health efforts. The CDC's Preventive Health and Health Services Block Grant allows for considerable flexibility in the use of grant dollars. The federal government provides approximately 53% of state public health funding. Local health departments obtain funding from a variety of sources. Small, rural, decentralized local public health departments receive more per capita funding than larger, urban, centralized departments.